Hello, everyone. I'm Professor Subodh Dave. I'm the Dean of the Royal College of Psychiatrists, and it's my pleasure to welcome you all to the latest edition of our Dean's Grand Rounds. Those of you who have attended before, you'll know that this is a unique kind of journal club, which is aimed at reducing the gap between evidence and practice. And today, I'm really delighted to have a very exciting topic. It's about integrating perinatal and infant mental health services in resource constrained settings, creating a one-stop shop using a public mental health approach. I'll introduce the speakers to you in a minute, but we've got over 800 people signed up to attend this webinar today. So really delighted to welcome you all. Some of you will be watching on demand. We would like to give a special welcome, especially to people who are joining from overseas in different time zones. Do feel free to use the chat function to say where you are logging in from today. But if you're planning to use a question, if you plan to put questions to the panel, I request you to use the Q&A box, please, because we will not be picking up questions from the general chat. And on demand will be available later, and so the event is being recorded, and the recording will be available to watch on demand via the RC Psych website, as is in the past. All registered delegates will receive an email notifying them once the recording is available to view. And the previous Dean's Grand are also available on that slide, so you should be able to do that. And speaker slides will also be uploaded to the website after the event. And if the speakers give permission, then they will be available for you to see. And certificates of attendance will be sent out within a week of the webinar to all of you who have attended live. So may I now introduce all our speakers to you, but a quick hello to Deepa. Deepa is the lead for the Dean's Grand Rounds, Dr. Deepa Vaghapalli-Krishnan, and also perinatal psychiatrist. So welcome to Deepa, and thanks to you for all the work that you do in running the Dean's Grand Rounds so effectively. And also to my colleagues, Dr. Abdul Rauf, who's the chair of RC Psych Learn, just led as head of events, and the team here and the staff, Keza, Nat, and Bethany. Can we go to the next slide, please? And let me now introduce our distinguished panel. So we've got some really exciting and very learned group of clinicians, and they're representing some fantastic bodies. So we've got Dr. Lavinia Lumu, specialist psychiatrist, honorary lecturer at the University of Witwatersrand, which you will know is a very well-known university. Nelson Mandela came from there. And most importantly, she's president-elect for the International Marcy Society for Perinatal Mental Health. So most of you will know that Marcy Society is the buzzword in perinatal mental health. So congratulations, Lavinia, and we really look forward to you. Our next speaker is Dr. Bhavi Vaithilingam, honorary lecturer in Department of Psychiatry, University of Cape Town, again, a very famous university. And Bhavi, you are from the Executive Women's Mental Health Special Interest Group in South African Society of Psychiatrists. And we're really honored to have the president of SASOP, which is the South African Society of Psychiatrists, Dr. Anusha Lachman here as well. And Anusha, you are also the clinical co-chair and clinical care work group of AGMHI, which is the African, I'm going to get this right in a minute. If you can just bear with me. Maybe Anusha, you can step in and tell me the whole form of AGMHI, because it's obviously escaping me.
But it's the Africa Global Mental Health Institute.
Africa Global Mental Health Initiative, yes. And work across USA, Boston, USA, and Africa, which I think is an exciting piece of work that's happening there. And you are a child adolescent psychiatrist, of course. So, well, over to you all. I'm going to sit back and watch. And I think hopefully we'll have lots of questions from the audience, and we'll all interact at the end towards the with the panel discussion. So over to you, Lavinia.
Thank you. Thank you so much for the introduction, and thank you so much for this platform. I'm going to start off by sharing my screen. We're going to go straight into a patient interview. Before we get into that, just a brief introduction. So how the format is going to work is that we're going to start off with a patient interview, a video. Patient so kindly agreed to participate in this. and then I'll go into my presentation. So just a little bit about the patient. Her name is Zinhle. She's 34 years old. She's Zulu, and she has a BA in communications and an honors. She's married, and she has 2 children, 13 years and 5 years old. And I saw her at a government hospital. She was recently unemployed and presented at 32 weeks gestation. This was at the time of the interview. A little bit of obstetric history. She's she's para 2 with a gravida 4 with a miscarriage, and she's had previous cesarean sections twice, actually. And her 3rd pregnancy is accidental because she had a failed bilateral tubal ligation. In terms of psychiatric background, her index presentation was in 2018. At that point, she presented to the private sector, where she was diagnosed with depression. Medication that she's currently on and stable on is fluoxetine 20 milligrams and quetiapine 200 milligrams Noctare. So before we get into the interview, just a little bit of some background and some context. So it takes place in South Africa, in Johannesburg. And I mean, everyone focuses on Cape Town, but I'd like to showcase Johannesburg. I know it is classified as quite a violent society, Johannesburg City. The interview takes place where I ran a maternal mental health clinic at that point at the Rahima Musa Mother and Child Hospital. And this hospital has quite an interesting history. If we go back to 1944, which is during apartheid in South Africa, where this hospital is situated in what was demarcated as a colored location for colored persons. And in South Africa, the term colored represents a racial group of persons of mixed race. And even today, they proudly so, a distinct racial group where they are mixed race. And I know in some parts of the world, specifically America, being called colored would be termed derogatory, whereas in South Africa, they're quite proud of it. So the hospital is based in Coronationville, which was then called the Coronation Hospital, but it only served colored people. And then in 1955, the hospital opened up to Indian people and Black people at that time. And then if we fast forward to 1994, when democracy came through, the hospital went through numerous changes and was renamed to the Rahima Musa Mother and Child Hospital. And this was in 2008. And why? I thought about why call it the Mother and Child, or the Rahima Musa Mother and Child Hospital, and some interesting history about the person Rahima Musa, who was herself an activist who dropped out of school to fight against apartheid. And she is pictured here in 1956. And this is at a women's march. And during apartheid, what happened was on August 9th, 1956, women took a stand to march against discrimination and the passes that all non-white women had to carry. And Rahima Musa was pregnant at the time of this march, and there she is pictured with Lillian Goy, who also has a hospital named after her, and Helen Joseph, who also has a hospital named after her, and Sophie Williams. So just some colorful history around what is now the Rahima Musa Mother and Child Hospital. With that being said, and that background, we can then now proceed to the interview. Thank you.
All right. Okay, Richard. I just want to say thank you so much for agreeing to do this interview. Okay, you're doing the interview. All right. Initially, when you saw the obstetric doctors, because previously with your son, when you came here, obviously there wasn't mental health services here. So you've had now the experience of being referred for mental health services. Take us through that experience. I would highly recommend that all females, all pregnant women need to be at some psychiatric help during pregnancy. You might think you don't need it, but we do need it. You need that professional help, someone who understands the journey, who will be there with you, who is able to offload, see once a month, assess how you are doing mentally. Because, when you're pregnant, honestly speaking, you're not the same person that you are when you're not pregnant.
Yeah.
And all pregnant women don't understand it. For me, it changed a lot. I can confidentially say, like, I was a crier before, all tears and emotions, but after starting seeing you, there were no more tears. You think, you react, and then you do, like, it's a journey. So that I believe that when you're pregnant, the gynae and the therapist must go hand in hand in this journey, because we go through so much. And that whole, not everyone understands the journey of being pregnant. Some days you might feel moody, some days you might feel happy, some days you want to offload to some people, to someone, you don't have that support structure. Because you can offload to someone once and then they'll be like, you're always telling me your problems, like it's heavy. We all have problems on this planet. So at least offloading to someone who's a professional who understands, it's much better.
Okay.
So you touched on something, your family, as you know, being Black in South Africa, right? How has your family, received or supported you on your mental health journey? I think when I first got diagnosed with depression, my mom didn't understand it. She was just like confused, saying, "What is this depression? Like, you get food, you work, like you're okay. What's depressing?" And she had to go through that journey of being a parent and learning about depression. That it's not something that you put upon yourself and you wake up in the morning like, "Oh, I'm feeling depressed," as cliche as it may sound. No, it's things that have triggered you from your past that that's been your subconscious, that you've been cannot put it. You've been putting on hold, you've just been piling up a lot of things, and then eventually one thing happens and everything just bursts and you just feel a whole river of emotions. So for me, my parents went through that journey with me of understanding. They learned, they went to the internet, they learned, they spoke with my doctors. So when I first got diagnosed with depression, I'm happy to have confidence in it's honest. Because we live in a society where being Black, we're dealing with so many things, and depression is one thing that people don't understand, and it's such a big thing. Suicide is such a big thing. For me, a lot of people don't know that I was suicidal. I had to be resuscitated back to health when I attempted suicide. So, for me to actually have a second chance in life, that's just what I fight for every single day. Things might not be okay, things might not be exactly how I want to be, but the mere fact that I'm fighting with depression, depression is I can say depression is worse than being diagnosed with HIV or AIDS or cancer. I'm not saying it's at the top, but it's one of those level 5 things that people don't realize that they have, because people are dying from depression.
Right. So it's interesting you say that for you, depression is worse than having other.
It's worse.
Why do you think it's worse for you?
Because, how can I put it? It's like you've got two personalities. It's you and this other subconscious thought that you can't control. You don't know how to handle it. At least with HIV or cancer, you take a pill and it suppresses whatever disease or whatever illness in your body. But with depression, it's a mental thing. There days it says to you, you're ugly. Days it says to you, split your wrist. Can't handle everything. There days where you suddenly it says to you, cry for no reason. Like it's affecting your brain and your mental health. And it's uncontrollable. And this is why
you know, I would say that, so, and it's so sad that in South Africa, we don't have so much support in local clinics about this. Not a lot of education is given out there. Only people who've got proper medical help, you know. This was the first hospital government after that being true, where we can give a psychiatrist. About it's a private hospital, you obviously will get it that, you know, there's so many people who are quite let's be honest. They need this service, they don't know it exists, but they need it. And you know, being 35, so I've gone under the 80s kids, where our parents tell us, get over it. You've got a job, you've got food on the table, you've got to use, what are you competing for? They don't understand. Our parents did the whole 76 about date, they had to be strong, move forward, work, build a house, raise your kids, don't deal with emotions, kind of a thing. And for me, what I take, the learnings that I take from my therapy session, I implement with my parents because, you know, they're old now. They don't understand, like, they days when I see my mom and I'm like, do you know that you're depressed? You're not feeling okay to it. When I talk about it, I give her those learnings that I did to her. So, you know, it's something that I feel like as a country we really look into.
Okay, yeah. And then also, let's talk about the stigma around psychiatric medication. You taking psychiatric medication during pregnancy, how has that been for you?
I mean, let me take a step back. Taking medication, you have that stigma. People are like, what, are you crazy? Have you been to the uni? And anyone can take medication. It just balances your mental health. And then came the time when I was pregnant, I was scared because I only believed that just take your vitamins, take your calcium. Now I had a lot of questions to say, okay, is the baby gonna be safe? Is it not gonna make my baby tired? You know, am I gonna be okay mentally and everything? So it's good that we've got medication. It supports both pregnancy and mother at the same time, you know, with the activities.
So you've been on quite a journey. Yeah. All right. So at least, you know, now that you've received the help, you've had the privilege of having services in private and government, and including mental health services. So for you, from your experience, you know, you have described that it's like sort of a one-stop. Do you feel like maybe that's better, that the mental health services are within your antenatal care?
This is why I said to you at the beginning that every pregnant mother needs that psychiatric help. We go through so much treatment. Like it's a lot. It's a lot. We need that support. And if it must be like every hospital, every clinic needs to have that psychiatric, you know, lay person that they can just go when they go in the door and see, just talk and say, am I okay? Is everything okay?
Okay, so what you're saying is, even if it's a person who's there just to check in on the logs to say, are you okay? Sometimes that's what's needed.
Sometimes it's what's needed, sometimes we don't know because we're not, it's not some professionals, to be honest. But I can say I'm okay, and you can just say me like, you know that you're depressed. You know. Maybe we don't know what triggers miscarriages in most women, but we can mental health, always being stressed, high blood, always worrying and stressing, you know, seeing a psychiatrist lowers your chances of you using your baby because you're more relaxed now, you're calm, your questions are being answered to say, okay, no, calm down, don't overthink things, take things one day at a time. So this is why I really feel as though every single mother and child mother during their pregnancy needs to be seeing someone.
So just to end off, you know, when you started seeing us, you were smoking.
Yes,
And
definitely.
sometimes there's a link with smoking and mental health, and now you are 4 weeks
Yeah.
clean.
I mean, I used to smoke a box of 20 used to last me 2 days. What triggered my smoking was the overthinking, the stress, and all these things. But I'm nicotine free. I don't think about it. I don't crave it. I don't want it. You know, it's all in the mind. You know, if you have positive thoughts, if you've got support structure, if you're taking a medication, if you're looking after yourself, in life, we always, and especially being a woman, we always put other people first. And there comes a time when you must just stop everything, everyone, and be self and put yourself first. Say no. If you need to say no to other people, say no. They will get mentally angry. Like, that's what I've learned by generating not being pregnant. I'm going to be as selfish as possible, as long as I can still call where I like to.
Thank you so much, Zinhle. Wishing you all the best with your pregnancy. You've got what, 8 weeks?
8 weeks.
8 weeks to go, and thank you so much for agreeing to do this. And let's hope that your interview will help many people out there. Thank you so much.
Thank you. We'd like to give a big thanks to the patient who agreed to do this interview. It was quite brave of her, and I'm going to now share the rest of my presentation, where we are going to do some reflections with regards to the interview. So yeah, I'm going to do a brief talk on the reflections on patient-centered perinatal mental health care. So I just thought that to take some key points, reflection points from the patient interview for us to ponder on, and to start off with pregnancy and what her thoughts of pregnancy are. And I found her statement very interesting, where she described being pregnant as one not feeling like themselves. You're not yourself when you're pregnant. And I think that's quite key when we talk about mental health and its onset, mental illness rather, and its onset in pregnancy, and why people are more predisposed to developing mental illnesses during pregnancy. It's because of these changes that happen in the body with a surge in all the different hormones that contribute to a person not feeling like themselves. And the next reflection point is what her thoughts were around depression. She described it as that there are two parts in one's mind, one that you can control, and then there's this other subconscious, uncontrollable part of the mind. And I think that's quite key. The subconscious, uncontrollable thoughts that one goes through. And I think that's quite important, because often people think that something like depression is something that a person can control. And people are still unsure if depression is a real illness. And this is quite important, because the World Health Organization estimates that it is a global disease burden sitting at 4.3% worldwide, and that by 2030, depression will be the leading cause of premature death and increased years of living with disabilities. So that's quite important, that from the patient perspective, she has highlighted that depression is a disease that is uncontrollable, and that attention needs to be paid to it. And also, another interesting theme that came through was that of intergenerational trauma. And looking at intergenerational trauma, statements that her parents would make, such as "get over it," be strong, move forward. You don't have to deal with your emotions. And the statement that she said that, look, her parents had to survive the trauma of 1976 and apartheid. And for people who are not aware of South African history, in June of 1976, throughout the country, pupils, children, school-going children throughout the country took a stand against the proposed introduction of Afrikaans as a medium of instruction and Bantu education throughout the country. It was quite a huge protest that led to students, school-going children being shot at by police. So that's part of the traumas that people have endured in South Africa. So, which brings us to the concept of intergenerational trauma, which is an emotional or psychological traumatic experience that happens to a group of people, and it affects their health and well-being, and it carries on for successive generations. And the impacted generations then also develop signs and symptoms of depersonalization, emotional numbness, poor coping mechanisms, resulting in various psychiatric sequelae. In actual fact, they're at higher risk themselves of developing various mental illnesses. And the next point that she touches on is stigma, and how one would even say that depression is worse than being diagnosed with HIV/AIDS or cancer. And stigma is a huge barrier in terms of accessing perinatal mental health services. And it's sad that this happens because we still are struggling with a lack of knowledge of mental health treatments, and this then drives the stigma and prevents access to effective screening, treatment of common perinatal health conditions, and poor outcomes. And also with regards to reflections of mental health in South Africa, how she says that there is no education on mental health and clinics don't have mental health services. And ultimately, in our country, we have a huge gap between rich and poor. Most people are poor and cannot get help. This reflects what is currently happening. We have really high prevalence rates of depression. In the perinatal period, it is as high as 39%. And we've got so many complex biological and social determinants that we're dealing with at the moment. We have a post-apartheid socioeconomic and cultural context. We have a prevalence of HIV in pregnancy that's still sitting at 30%. We have a high prevalence of food insecurity and increasing non-communicable disease burden. And also, we are also grappled with increasing rates of intimate partner violence, especially during pregnancy. So we do need to pay attention to these services. And she does touch on how these services in the perinatal period would look like. And it would look like possibly a one-stop for all health services in pregnancy so that it's accessible for women and doesn't have to be a high-level psychologist or psychiatrist. I mean, we have a great shortage of mental health professionals in South Africa. She just said, just having someone to ask, are you okay? Just having someone to check in with me. That is all that is required in starting the process of providing perinatal mental health services. With that being said, I just wanted to say a few words on quality of care. And quality of care is the degree to which health services for individuals and populations increase the likelihood of positive health outcomes. And the developmental goals area of quality of care is essential to ensure strengthened capacity of all countries in health risk reduction and management. And in terms of quality of care, and this is a a concept, because we focused mostly on providing perinatal mental health services, but now the goal is to try and see how we can and focus on quality of care. And it focuses on the following concepts, where care should be effective and based on evidence, and care should be safe, do no harm, and it should be patient-centered. Quality of care or healthcare should be patient-centered, providing care that responds to individual preferences, needs, and values. And to realize the benefits of health, this healthcare, quality of healthcare, the services must be timely, where there shouldn't be long waiting times. It should be equitable, which is a challenge in our setting because of the extremes in terms of rich and poor. It should be integrated, which is a goal for perinatal mental health services, and it must be efficient. So there's some studies that have been done that focus on quality of care, specifically in sub-Saharan Africa. And looking at quality of care, the research is very worrisome, and that it has demonstrated poor quality of care, where there is a high prevalence of mistreatment, abuse, disrespect, and neglect of women. And what's quite unfortunate is it's at the hands of frontline health workers. And studies have been done across Nigeria, Ethiopia, Tanzania, and Kenya. And the rates are very high as up to 98%, where one or more categories of disrespectful and abusive care have occurred during childbirth. If we zone in on one particular study, and this study was done in Uganda, a qualitative inquiry where they focused on the challenge of providing patient-centered perinatal healthcare in a rural setting in Uganda. So they conducted this study to obtain a deeper understanding of how interpersonal dimensions of quality of care relate to real-life experiences of perinatal care in their setting. And the findings were quite intriguing. So in summary, they found that despite individual health provider efforts, there was a significant reported negative interpersonal interactions, while the mere provision of perinatal health services was often mistakenly perceived as a positive patient-provider interaction. This is quite important when we try and disseminate these services. They also found that there were poor interpersonal quality of care instances, which included neglectful, duplicitous communication, verbal mistreatment, negligent behaviors from healthcare workers towards perinatal women. And the ultimate consequence is that it created the cycle of ineffective utilization of perinatal services. And that is a concern, because that poor quality of care could potentially result in negative maternal and infant outcomes. And looking at another study of women's experiences of specialist perinatal mental health services, and this is a qualitative evidence synthesis, and this is more in a higher income countries were involved, the UK, Ireland, Canada, New Zealand, and Australia. And what they found is they had the usual, systemic level barriers that one would expect, but there were other barriers where women were reluctant to access perinatal mental health services because of often the fear of stigma, losing their parental rights, or being deemed an unfit mother. This is the stigma around being diagnosed with a mental illness, or the logistics of attending appointments when caring for small children. So this study is another contrast to say, when we offer these services, to find ways to make them more patient-centered. So in conclusion, supporting perinatal mental health can improve overall maternal health outcomes and the quality of maternal and child health services for all women can be improved by simply creating environments where these patients feel safe to discuss their challenges in a respectful and caring environment that is free from stigmatization, and that the provision of patient-centered perinatal mental health should be our goal. And when we are integrating perinatal mental health into global maternal health care. And with that, I'm going to stop my share. Thank you so much for your patience. And I'd like to hand over to my colleague, Dr. Bavi. Thank you.
Hi there. Thanks, Lavinia. That was really great. I've seen your presentation before, but it was so interesting to listen to it again. I'm going to start sharing my screen now. So if you'll just bear with me. Okay. So I'm going to talk more about integrating perinatal mental health into obstetric care. And like Lavinia, I'm a perinatal psychiatrist, and I have worked in a state hospital in Groote Hospital, setting up a perinatal mental health clinic within the obstetric services. And in this presentation, I'm going to look at some of the literature around perinatal mental health services in obstetric services, but also look at some of the gaps in that literature and what we can do to try and address this. So as Lavinia said, is that we have this much higher burden of disease in Africa, as high as 39%. And as you can see, this is a significant public health problem, both for mothers, but also for infants and for families. So if we look at implementing combined mental health and antenatal services, the problems that we have when we look at Africa is that, one, there are not many studies, and the studies that do exist are mainly small and qualitative in nature. They've looked at a single clinic or a few clinics rather than big district services. But what they do show is that combined services really are welcomed by women. And this really does mesh with our clinical experience in running these services. Women do want one-stop shops. They want to be able to come to their antenatal or perinatal clinic and get mental health services in the same place. So if we look at studies, and I think Lavinia did quote one of these studies, the one from Uganda, but also studies in Africa and Mali. These are all qualitative studies. That is a theme that goes through my presentation. We don't really have quantitative care. But all these studies looked at the extent to which the integration of perinatal mental health was considered opportune. And the thing is that everybody who works in perinatal mental health and most people who work in obstetrics actually perceive this to be a worthwhile endeavor. And midwives, who I think are the backbone of obstetric care throughout many societies, but particularly in Africa and South Africa, our obstetric care is midwife-led, as I think yours may be in Britain. They really support mental health care being integrated into obstetric care. I want to say a little bit about teen pregnancies and adolescent girls. Africa, we are growing rapidly. We have the youngest population in the world. And the problem with teen girls, adolescent girls, is that they're a high-risk group. They are high risk both obstetrically and high risk in terms of mental health. But the problem is that there are limited mental health interventions. And what we really need is to involve and educate the community. You know, unfortunately, so often these girls get pulled out of school, there's stigma against them, and they're not given the care, especially in terms of their mental health, that they deserve. So let's look at some of the barriers to integrated care. And you'll see stigma as my first poster there. And you've heard this from Dr. Lumu. Stigma, stigma, stigma. Over and over again, stigma is preventing women from getting care. Both stigma in the services as well as stigma, self-stigma in the women themselves. What these studies did find, though, is that midwives often lacked specialized training and they felt very ill-prepared, which perpetuated stigma and therefore referred all women. However, medical staff, on the other hand, who had more level of training, were more likely to screen and more likely to actually treat women at point of care than refer them on. So for me, the take-home message for this is that in order to screen, we must also train the screeners and train the staff in clinics to pick up mental health problems and also to have some plan for how to manage it. And if we just look at structural barriers to perinatal mental health care, and this is a very busy slide, so I'm just going to go through it briefly. For one, mental health care is not prioritized in our health services, and perinatal mental health care is particularly poorly prioritized. There are also socio-cultural barriers. As the patient who was in Dr. Luma's video explained, her parents, her culture did not recognize mental illness, training barriers, and then individual barriers where individual healthcare professionals cannot actually overcome their stigma or are poorly trained. The next study I'm going to talk about looks at maternal mental health care in lower and middle income countries. They looked at 5 lower and middle income countries and 3 African countries, Ethiopia, South Africa, and Uganda. And these studies looked at the impact of maternal mental health disorders as well as alcohol use disorders, which was really interesting because a lot of studies don't look at alcohol and substance use disorders. And this is really, really important. As we know, there are many pregnant women who are using, and this has a massive impact on their mental health, on their child's mental health, and also their risks for postnatal mental illness. But what has been found is that none of these countries had a dedicated maternal mental health care service. South Africa and Ethiopia had a policy, and South Africa was implementing a plan, and in fact is implementing a plan for perinatal mental health care, but we're not there yet. So what are the challenges? There's a lack of maternal mental health specialists. I mean, there are not enough psychiatrists to go around, and there's certainly not enough perinatal psychiatrists to go around. There are no clear prescribing guidelines, and then again, the very stigmatizing attitudes. Again, looking at Malawi, what they found was that delivery and approach had to be very careful and must be acceptable to clinic staff. You cannot just come in and impose a service. You have to make sure that it's acceptable to the staff and include looking at what the local reality is. If we look at an actual maternal mental health service that is set in South Africa, they actually say it in Cape Town at one of the clinics where I've worked. This is a primary level obstetric facility where women are screened using the Edinburgh Postnatal Depression Scale, which I think you're all familiar with, and then a locally developed, validated 11-item risk factor scale. And any woman who screens positive is offered counseling in the clinic by dedicated counselors. Unfortunately, only just under 60% accept counseling. And we need to really improve the uptake, especially among young women, because as I mentioned, young women are at greater risk. So why are women not taking up treatment? Stigma, time away from work is a problem. What we hear time and again from people is that their employers will not let them take time off work. And it's often a whole day of work because they've got to take transport to the clinic, they've got to get transport back, they've got to wait, it's often not booked appointments. And then again, the actual cost of transport. Africa, we don't really have rapid mass transport systems. We have public transport systems, but those are generally run by private companies. So transport is really expensive and it's difficult for women to actually come in for a service. So women prioritize. Unfortunately, because of stigma, they don't see their mental health as that important. Therefore, they will rather prioritize the obstetric visit rather than the mental health visit. The next study looks at mental health in tuberculosis, which I'm not going to talk about, but very importantly for us, maternal child healthcare services in 4 South African districts. And they looked at the people who run this, the district program managers. And this study was interesting because they were one of the few studies that had quantitative data. In South African clinics, nurses are supposed to use the PHQ-9 as a screening tool. The PHQ-9 is a patient health questionnaire 9. It's a 9-item tool. And they're supposed to screen at every visit, but only 73% screen, and only 4% are actually, 44% are actually using the PHQ-9. The district program managers believe that there is a stepped care approach, but this is not really happening because only 7% of people were treating mental illness, and that's a problem. So how do we prepare our nurses, our midwives to actually treat mental illness? So one of the ways we can do this is what's called the secret history method. This was developed by the Perinatal Mental Health Project by my colleague, Dr. Honigman, and others. And one of the problems is that nurses are often abused in maternity settings, and nurses often abuse patients. It goes both ways, unfortunately. And the secret history creates a space for nurses to reimagine the relationship that they have with patients, to confront their own trauma, because many of these women have delivered in public health facilities and have experienced significant trauma, and to prepare the environment to task shift from mental health from secondary and tertiary services to primary services. So how do we practically train midwives? As I've said, stigma, where there's this vicious cycle of lack of knowledge and stigma. And the big question is screening. How do we screen? There are many tools in which to screen, and the EPDS is probably the one most of us in perinatal psychiatry know best. The problem in South African settings is that the EPDS is a bit longer and it has to be reverse scored. And this can be complex for lower levels of carers, not professional nurses, but very often we have nursing assistants, and they find the scoring difficult. Short is very important because when you are seeing a clinic of 200 and 300 people per day, you don't have time. It must be acceptable to both staff and patients, and we must validate it. And lastly, once we screen, we need to know what to do for the screen-positive woman. But we've talked a lot about primary health care. What about secondary and tertiary care? Where are the psychiatrists? We don't have studies to tell us where the psychiatrists are. They're certainly not in the studies. Our experience is myself, Dr. Lumu, others who run perinatal mental health clinics in South Africa, is that psychiatrists in the public health sector are really dealing with an absolutely overwhelming burden of very behaviorally disturbed patients. In South Africa, our psychiatric wards are full of patients who are very psychotic and very behaviorally disturbed. But we don't have data to say that this is why psychiatrists are not in perinatal mental health clinics. As Dr. Lumu mentioned, we have a growing inequity in maternal mental health care. The studies look at general health access, but the concerns are around obstetric care in terms of planned pregnancy and antenatal access. And the question we have to ask is, can we extrapolate this to maternal mental health care? And we really need studies to tell us this. But what about maternal mental health care in the private sector in South Africa? South Africa has a really booming private healthcare sector, and there's very active and dynamic maternal mental health care. The challenge is to mesh this with the public sector so we can make this available to women in the public sector, so poor women can get treatment. And what we need is appreciation of trust and appreciation of each other's expertise. And we need to look at some way of rewarding the private sector. And that does not have to be monetary. Many people in the private sector are happy to work in clinics for things like library access. You know, if you work as I do in the private sector, you don't get library access. But if you are an honorary lecturer, you do. And it's great to have the journals. Access to academic activities and the team approach is just so rewarding. There was a question asked on the chat about what motivates us, and I think this is part of it, the team approach. So we really need pilot projects, to evaluate these public-private partnerships, and how do we then upscale them? So just to summarize, maternal mental health is a major public health problem. Across Africa, we have stigma, we have lack of education of staff, and these are barriers to maternal mental health. Adolescents are a particularly high-risk group, and it's really important that we change perceptions and upskill our nurses and midwives. We must integrate with psychiatric services as well as obstetric services. Maternal mental health cannot stand alone. We need to be integrated with all these services. But really what we need more than anything else is more data on service effectiveness. So I really want to thank you for listening. I'm going to stop my screen sharing now, and I'm going to invite Dr. Lachman to start her presentation.
Royal College, for the opportunity and the privilege to be able to present on this platform. And I think it will tie in quite nicely with what our two speakers before this have talked about, where we've talked about the challenges. And I'm hoping now that I'll offer you an opportunity to rethink how you can address the training, the education, and the research that's missing in order for us to bring this all together. So I just want to mention again that and acknowledge that we are hosting many organizations here today, and that is our South African Society of Psychiatrists, the Africa Global Mental Health Institute, and of course my academic affiliations to Stellenbosch University. We can get ahead. So I think it's useful always to set the scene. So there are 250 million children younger than the age of 5 that live in low middle income countries that are estimated to be at an elevated risk of not achieving their human potential. And that is primarily because of exposures to early adversity in the first 1,000 days of life. Now, there are many identifiable risk factors. Some of them, unfortunately, are disproportionately present in Africa, and this contributes to the loss of human potential. And again, unfortunately, opportunities for adequate screening, as you've heard, which is needed, early recognition, intervention for both caregivers as well as infants are limited. It's often under-resourced, it's underfunded, it's poorly supported. There's sometimes just no resource commitment to implement this. This is one of my favorite slides, and that's to remind everyone in this audience that Africa is not a single country. Africa is home to multiple cultures with distinct organizations of caregiving relationships, and context-related limitations continue to constrain our global and international understanding of children, of their parents, and their future development. Africa, we know, remains an understudied continent, especially when it comes to perinatal mental health, infant and child relational risks. But in its diversity, there is a belief that many important truths that are necessary for us to understand better how we relate and the complex relationships between caregivers, especially those who are mentally ill, and their children need to be understood. So despite clear evidence, right, we know that if you invest early, your outcomes are better. But despite this knowledge, there continues to be an under-prioritization, underfunded, inaccessible opportunities for the population to reach services. And Africa is no exception to this. In fact, a scary stat is that UNICEF projects that the expansion of Africa's child population will increase to 1 billion by the year 2030, with a disproportionately small availability of healthcare personnel. And to put this in reference, our population of children in South Africa currently sits at about 17 million children, and we have only 35 registered child psychiatrists in the country. So you can imagine we have no personnel, no human resources to meet this demand. And so we have to think creatively, we have to think innovatively about how we can reimagine offering universal access to healthcare on the continent. And while that might be a really good, effective concept for us to talk about, the question is, who is going to train everyone? Where do we start? What do we do in areas when there are no healthcare professionals that are available to provide the services? And if there are healthcare professionals, what happens when there are fragmented health systems and there are resource-depleted healthcare services? So what we thought we had to do in a way was we had to reimagine and in a way reinvent the role of higher education and training in order to try and address this need. And child and infant mental health, there's really an rapidly expanding service need across the continent, but also a good opportunity again for us to rethink perinatal mental health. Now, the expansion of infant and child mental health services in Africa relies largely on the provision of education and training. And for this, there needs to be an effective training infrastructure. Again, a reality is a good reference point. In stark contrast to many international standards of care, you may have lots where you are. The African continent has offered to date no professional postgraduate degrees that focus on multidisciplinary upskilling and education. There are a few pockets of really good training programs when it comes to psychiatrists and medical doctors and nursing, but really the bulk of the healthcare service providers are actually not medical professionals. So we thought there was a need to develop an interdisciplinary graduate program to almost prepare a diverse workforce prospectively to be able to feel more comfortable to intervene. And early infant mental health seemed an appropriate place. And just to mention that most of the offerings that have been available to us in the field of IMH have really just emerged from the global north and, quite frankly, are unable to respond to the need in Africa. So the question is, why is it so hard to establish and to integrate infant, child, and maternal mental health into general services? You've been hearing so far about how there is this need, there's this desire from both professionals as well as patients. So why is it so hard? And the bottom line is it's expensive, right? Child and adolescent mental health services require integration into already burdened and under-resourced services. And unlike infectious diseases, for example, where you can give an antibiotic or an antiviral and you can, do an intervention that fixes a broken limb, when we think about mental health, it usually involves systems. And systems that surround the child and the infant involve more than just the baby. So it's about structural contributions, family systems, caregivers, etc. And the care of the child or the infant depends on the care of its caregiver. And as you've just heard Bobby talk about, that's clouded by stigma and barriers in accessing services for caregivers themselves. But it's not that simple, as in let's just train someone in infant and perinatal or child mental health. We also have to offer supervision. And so skills are nuanced. The requests for reflective supervision at basic level services are great. And what is problematic for us is that we often have to compete with other health priorities. So things, especially in South Africa, Sub-Saharan Africa, TB, HIV, those are considered core, more life-saving conditions. And so obviously that gains more political priority than mental health. And the difficulty, as you've also heard, is we have no data. There's limited, if any, data that specifically addresses perinatal and child mental health and its unique requirements on the continent. And in fact, the research that we do have from public mental health and public health policy agendas shows that services for children, specifically for mental health, is not really considered priority on the health policy agenda. And one of the reasons we often kind of come across is that there is a lack of knowledge and quite this erroneous behavior. When we talk intervention, when we talk early childhood development, they immediately think this means school and this means interventions. And so people say, well, we have ECD centers, and we have early childhood education. And we know that's not the same thing, because when we talk about intervention, especially for perinatal mental health in the first 1,000 days, we talk about psychosocial interventions and we talk about psychological support for caregivers and infants. And unfortunately, this seems to fall outside of the realm of what's considered sciencey, biomedical interventions. And so therefore, we are less likely to compete successfully for research funding. I want to draw you back to why I'm using infant mental health today as the example, as a potential model that can answer and maybe address a little bit of this need. So Donald Winnicott, who is a very famous pediatrician, said, there's no such thing as just a baby. And what he was trying to say was that a baby doesn't exist alone, but is essentially part of a relationship. So infant mental health as a field connects babies with their caregiving relationships. And so mental health challenges itself in that perinatal period in the caregivers continues to be overshadowed by the systemic issues in the health system and therefore impacts in the long-term outcomes of babies, which is what we're interested in. We want children to thrive and to live their best lives. And we felt that this can be addressed in small ways, maybe, by general and mental health care professionals, encouraging more of an awareness of the impact of perinatal mental health on early infant services, as well as trying to encourage and support dyadic screening and intervention. But to do this, which kind of sounds great on paper, we have to be able to screen effectively. But to screen effectively, we have to use appropriate tools. We have to know how to screen, when to screen, who must do the screening, where must they screen it, what happens when you identify these red flags, who must actually do the interventions. And to go back to the stat that I've used, about 35 child psychiatrists in the whole country, there really cannot be an expectation that perinatal, infant, and child mental health can only be managed by experts, because given this limited human resource, we will fail to reach the majority of our population. So the idea is that we have to meet patients where they are. And very often, that's not in the psychiatrist's office. That is in primary healthcare services. People access immunization clinics, antenatal spaces, and very often GP practices, but they are not accessing mental health care services. Then the other question we have to think about is, it's all good and well to say, let's screen. And you may or may not have doctors, or you may or may not have material resources. But what is that evidence that you're asking them to screen for? And we have to think about the very evidence quite critically. So for example, are we saying that all children are the same? Are we saying that all families are the same? Who decided what is relevant in which setting? What tools do we use? Do these tools actually assess and respond to mental health challenges? Where were these tools developed? How culturally relevant are they? Can we actually use them? Should we actually be using them? Do they actually respond to the needs in an ethnically diverse setting and a limited resource setting? And these are really important questions for us to consider. So the good scientist sitting here will say, well, you know, before you say evidence is not good, why don't you prove it or disprove it? And the idea is that we have to investigate, we have to research, we have to replicate, because that's what the good scientist does. But I'm here to remind you that we have to critically evaluate what that good scientist says. And what about the evidence that does exist is problematic? The problem is almost all parent-child intervention programs to date have been supported by ideas that have been developed in North American and Western European settings. And the question you should be asking is, who is represented in those gold standard algorithms that you want us to test, research, and replicate? Most of them originate from settings of predominantly white, privileged, homogeneous samples of women and children in Europe. And so when researchers say things like evidence-based guidelines are adapted and validated, what do they actually mean? Do they mean they're culturally appropriate in the situation that we're in? Have they been tested in a setting different from the West? Or have they just been translated into another language? And this is a really important thing to consider, because where does our evidence come from and where is it published? And so there's this movement for us to really call out in academic circles this lack of diversity and representation. And these are really two really good articles that have come out in 2023 that I encourage you to look for, because what that does is it asks you to challenge the high income country publication biases that produce this work. There's a lack of diversity and representation in editorial boards. And by that, I don't mean race-wise. I mean the people who come from settings outside of these high-income country settings. And what it creates by only publishing articles and evidence that originates in these different regions, in these privileged regions, is that it makes it an unfair playing field. And we have evidence that originates that's simply not true. So take, for example, poorer brain development in the global south. What does it even mean? Who's decided that? Have they used a set of tools that actually have been normative validated against children in Europe? And we're asking, do African children meet the standard or do they fall short? And so these are the questions we have to ask, because bringing it back to infant mental health, in our university in 2003, at the Department of Psychology, Mark Tomlinson and Leslie Swartz reported this fascinating study that said only 5% of all infant research in major journals originated from parts of the world outside, other than Europe, America, and Australasia. And a decade later, the same group went back to say, well, you know, we've made it known that there's a lack of diversity in publications. And with this awareness, How much progress have we made to publish other work? And here's an interesting stat for you. Only 2% of articles published in 10 years, think about it, 2% of articles included data that originated in low middle income countries, where 90% of the world's infants live. So take a few seconds to think about that. We are promoting interventions, screenings, tools, evidence-based kind of ways of practice on children that live in a part of the world where their representation only makes up 2% of all that evidence. How is that even scientifically okay? And so I'm not here to say that we need to throw out the baby with the bathwater. Of course, principles of existing models of intervention, training, and teaching are important. They're useful, they're applicable, but we still have to look locally. And we have to ask ourselves, what are those contextual factors that will include things like you've heard Lavinia talk about, the ongoing legacies of apartheid, of racism, of social inequalities, these psychosocial determinants of mental health. And we have to also include cultural variations. So for example, in South Africa, most babies are not looked after by their biological mothers because biological mothers are looking after other people's babies. And that's because they have to go to work. So babies are collectively reared often by aunties, by grandmothers, by neighbors, by creches. And so we have to think about that when we try to navigate this field with a singular approach, like let's do mother-baby intervention. What does that mean if the mothers are not looking after their babies due to these acceptable circumstances? So to address the need in South Africa, which is shortage of trained clinicians, who can assess, where must they assess, how do they assess it? How do we resolve this gap in human resources? And one of the ways we do that is by the principle of using non-specialists to deliver mental health care. And so that is a term called task shifting, which is quite a successful model of delivering healthcare using allied healthcare workers, community health workers, nurses, for example, in the community where patients are, using them to be able to reach those difficult to reach populations. And to address this, an example of this is Professor Astrid Berg, who is the current president of the World Association of Infant Mental Health, who's a South African, and myself developed an MPhil program, a master's program, to try and address this need to upskill and task shift by training healthcare providers, so a diverse group of them, including dietitians, OTs, nurses, psychologists, and a doctor or two, in a way that we rethink the services that are offered, and we try to create a program that's centered in an Afrocentric way. So while we did core theoretical modules that include attachment, infant observation, we do a research project, we also try and contextualize things. So for example, we want to promote co-sleeping in preterm babies because we know that we have the highest rates of preterm deliveries, and we know that one of the most effective methods of improving outcomes for babies who are born preterm is kangaroo mother care. And we can only do that if you co-sleep with your baby. So again, we have to be able to differentiate what are these like kind of commonly thought of ideas that are not practically applicable in South Africa. For example, putting babies back to bed when we actually want them to encourage kangaroo care, just as a random example. But again, this is not necessarily a model that just works. We don't just take a group of diverse professionals and we say, here's a master's program and we're going to teach you all these things and we're going to make you upskilled, or we're going to task shift. Because the reality is that different professionals come with different experiences. And so we have to be able to test competency, to measure outcomes, to teach in a way that addresses this diverse classroom with their diverse challenges. And we have to also ask ourselves, what are we actually trying to do here? Are we trying to just create mental health experts, or are we trying to upskill non-mental health experts to be able to think in a more mental health friendly way? And so this has been quite an interesting learning opportunity for us that we have written about if you are interested. But some reflections on these is that we've decided that our course content, for example, needs to reflect multicultural sensitivities, and that's difficult. When we evaluate whether somebody's competent enough to take on that healthcare task, how do we test them? Do we look at how they write essays? Do we consider how well they speak English? Are we perpetuating some kind of colonial language competency marker? And can we think about this in a more inclusive way? And part of the thing, that the struggle was that we had to realize not everyone has capacity or time to do a master's program, and not everybody needs to do that. What's an easier way for us to make it accessible? And thinking about this, we were able to create an online short course, which we then launched last year. And I'm happy to say, you look at the price there, that's nothing in pounds, but really we want to make it accessible. And so anyone can do this course, where we try and package it in bite-sized pieces, so that even a mom or a school teacher or a social worker who doesn't have an honors degree is able to access this kind of Afrocentric, culturally, contextually relevant information that we want to kind of inform them around. And I'm happy to report that we've been able to train people from Uganda, Tanzania, and Nigeria so far on our online course, which is a short virtual offering. So if you are interested in that as well, we published this year in the Lancet our opportunities to accelerate progress, how we include perinatal thinking in that, and 2 years ago also in the Art of Medicine series. So the bottom line is there's no one size fits all, and we really have to address the challenge through a reflection of established models. What do we take that's worth it? Where do we calibrate where possible? How do we develop alternatives where we can't? And always remind yourself, we don't want to create experts in mental health. We just want to encourage other experts to think in a more mental health friendly way in their everyday practice. And so my last slide is just really some concluding thoughts that there's so much we have to learn about babies, about families, about perinatal mental illness by engaging in these questions, specifically in settings that don't look like our own or yours for that matter. And I want to emphasize from our experience of academics and research that we emphasize locally developed training programs with locally evidenced interventions that are best able to be placed to capture and include cultural nuances in teaching. And basically, I want to encourage you to think in a global social medicine way, that really knowledge is multi-directional, that we have to have a commitment to learn from others, and we have to relearn how we think about things. This can only be done in a multidisciplinary, transdisciplinary space with an openness and, of course, a desire to do better for our patients. So that's my last slide. I'll stop sharing. Thank you.
Thanks, Anusha. Thank you, Lavinia and Bhavi as well for all those fantastic presentations. And a big thank you for sharing that patient story and journey as well. We now move on to the panel discussions, and we'll take some questions that are posted in the Q&A chat. But before that, a few reflections from my side. I think the challenges that were highlighted in these presentations are kind of present worldwide, but some of them are quite unique to low and middle income settings. So the point I'm trying to make is that some of the initiatives that you have highlighted, Anusha, in Bhavi's presentation as well, I think there's a lot of learning that can be adapted to several settings from what we've heard. And I think it's quite important to place that emphasis on prevention. That's another take-home point for me, and focus on integrating maternal and infant mental health alongside antenatal and primary care services, so that they can be considered alongside physical and developmental well-being as well, and the importance of that tailored initiatives to meet the population needs, and as well as the cultural needs of the local population. So I won't hold up for long, and let's move on to the first question. And I think we have everyone who's in the panel here. So the first question, I think perhaps Bhavi, if I can pose that question to you. Given the limited research in the area of best practices for successfully implementing combined mental health and antenatal services in clinical settings, what in your opinion are the best practices?
That's a great question, and that's a difficult question to answer because there isn't a lot of research. Our experience in South Africa has been that the first step is to address stigma, to work with your colleagues, to work with the nurses, to really work with the obstetric team to get them to accept you into their clinic, because we as mental health professionals are going into an obstetric clinic, and very often we get seen as the outsiders or the interlopers. The next thing is, I think, to go in without any preconceptions, to start small, and to really get a sense of what your particular clinic looks like and what are the disease patterns in your clinic, what are the the skills of a nursing staff, and I emphasize nursing staff because that's who we work with primarily, but what are the skills of the people in your team? And I think if you start like that, you then develop a really good sense of what you need, and you can then modify your clinic.
Thank you, Ravi. Lavinia, do you have anything to add to that? I think that also links into one of the questions that's kind of answered already. So how do you prioritize which services need to be included in that one-stop shop model? So in those integrated service model setup. So is there anything you would like to add to that?
Yes, I'd like to agree that certainly is as trying to ensure that one is in the setting where all the patients come through. So I ran the maternal mental health clinic at Rahima Musa Hospital for 5 years. And I mean, the psychology department is on the second floor. And the pregnant woman wouldn't go, even though there's an escalator a lift to the second floor. So I made sure my office was right next door to one of the, registrar's offices. And, and I made sure it was the diabetic room to minimize stigma. And fortunately, the diabetic room was the most soundproof office as well. So, women actually didn't mind coming through because it was, you're just going for your diabetic check. Meanwhile, you're off to see me. So I think it is quite important to get a sense of the community that you're servicing and take it from there. And being as collaborative as possible. That's an emphasis as well. Thank you.
Thank you, Lavinia. I think that kind of emphasizes the fact that we need to adapt the services that we provide based on the local needs, as well as how the women perceive and the stigma as well. So my next question is to Anusha. So Anusha, there's a question in the chat about how can we address the resource, care, and training gaps in mental health services of children and caregivers in Africa. So more focused on infant mental health there and around training.
So is the question around how do we focus on child, not just infant?
Yeah.
So I think, the principle is the same. I used infant mental health as an example, but the idea is that this is what we have been, at least in our space in South Africa, in the child psychiatry space, that we've been trying to think about that, whether it's our CAM strengthening team, doing a lot of education and upskilling in the districts, our partnerships with international organizations, which include places like IACPAP, the Child Mind Institute, where we're trying to think innovatively how we can train these multidisciplinary teams in child and adolescent mental health practically, rather than us just kind of rely on the idea that there's one route to specialization and offering mental health care services. So I think the short answer to that is that it's a work in progress, and that we are trying to be able to really upskill in innovative ways, and that is largely through training and education. So we are doing that not just in infant mental health. I just use that as an example.
Can I come in, Deepa, just with a follow-up question, if I may? So, Anusha, this question is for you as well. And I think we heard from all of you, and I think you're emphasizing the integration approach. And I think, and you also mentioned about the focus on, the funding effort and the training effort on diseases like HIV and TB, which is again not unusual, as Deepa said, for Africa. We always see there's lack of that parity of esteem in terms of funding of mental health. Do you feel there's also maybe an onus on us to kind of try and join the dots? I've seen lots of, I used to support training in Zambia, and I saw that Bill Gates Foundation was working there. They trained something like 10,000 counselors in HIV. but there was literally no mention of, mental health, substance misuse, intimate partner violence. These guys were actually going into the communities and counseling people directly about HIV. And yet the other factors that I mentioned were so intricately linked with HIV, but there was no mention in the training or in their protocol about that at all. Do you feel there needs to be more joined up approach, not just within psychiatry, but also kind of broader, across a broader health and social care spectrum?
I mean, the short answer is yes, of course. But the difficulty is getting acceptance and buy-in into that space. And so what we are seeing quite interestingly is in spaces like infectious diseases, for example, in HIV, in TB treatment, that there is slowly an evolution of understanding that the diseases are not just a single biological disease process. And I think the more we talk about the social determinants of mental health, the more clear it is to people in other biological or physical health conditions that they actually can't do one without the other. And it comes out. It comes out in issues with adherence and compliance. So there's lots of relapse. The reason we have XDR TB, for example, drug-resistant TB, which I'm sure is the same in other places like in India, and in South America, is because there are psychosocial determinants that haven't been addressed, and untreated mental illness in the caregivers who are supposed to monitor and supervise adherence to these life-saving diseases. So I think there's a shift, there's a willingness, but it's come out of necessity, not because they think mental health is important, but because the untreated mental health issues and social determinants are impacting on their biological and physical health issues. So yeah, I guess that there's always work to be done. And part of that is we try and include ourselves and almost integrate ourselves into platforms for things like non-communicable diseases, even like diabetes and cardiovascular health. And we try to always talk about that from a mental health approach. So yeah, and I think that speaks a lot to the public health hat that we wear, public health and public mental health hat that we have to wear in leadership and also in kind of practical adherence to things. Yeah, so not enough is done, but I think that there's a shift.
Thank you, Anusha. I think there's someone in the chat requesting if they can access your training resources or if they can get in touch with you for some further support. There's also no comment there below on people wanting some mentorship in developing these training resources as well. I think Subodh has just typed about the public mental health course that the RC Psych is running. So if you can tell us a bit more about any resources that people can access.
Are you asking me?
Yes.
Oh, yeah. So I'm very happy for people to kind of reach out. My email address was there at the end, and we can maybe share that again. And not just from our program, but also within our society, the South African Society of Psychiatrists. So we have quite a wealth of experience and expertise, a range of kind of really context-specific mental health approaches. And while we are trying to develop training programs that can accommodate that and speak to the context and the relevance, we do have a wide kind of access to really experienced clinicians, trainers, educators, and researchers that, of course, are more than welcome and willing to offer that expertise and mentorship. So please, I encourage you to reach out, and I will direct that as appropriate.
Thank you, Nisha. I think there's quite a few questions on training here. So another question, perhaps everyone in the panel can answer this, and I think Subodh can perhaps also chip in from the RC Psych and UK training perspective. So the question is: is there any scope to implement infant and maternal mental health training into undergraduate training, internship, or community service year? As I'm assuming that's almost like internship year. For example, making it part of the portfolio for the psychiatry rotation, but also integrating it into other rotations such as obstetrics and gynecology and pediatrics as well.
I'll kick off on this first. I think the broader issue is that curriculum is always very tight. I think trying to put more in the tight curricular space is always a challenge. And I think where we stop. I think the main problem with medical education, which I think was highlighted in our presentations, was that it's not locally relevant. I think we teach medicine, but how do we make it actually relevant to the local population? So I think how do we, if you realize that you've only got 35 psychiatrists, child psychiatrists in the area that you practice, then clearly there's even more of a need, a burning platform there to be addressed in undergraduate and postgraduate medical education. That may not necessarily be the case in some other parts of the world. So I think curriculum designers, and we as clinicians need to hold our curriculum designers to account by saying, how are you making your curriculum locally relevant? I think that's the big shift that the Royal College of Psychiatrists has taken. I think our new curricula are very specifically addressed that you must not just be adept at treating the individual patient sitting in front of you, but how are you demonstrating your skill in managing the outcomes for the wider population? How are you learning the skill of improving the health outcomes for the wider communities that you're responsible for? And I think that's something that we should all contribute to. So that's a generic answer, but I think the point you make that all of these ideas should be integrated at undergraduate level is absolutely uncontested.
Thanks, Subodh. Is there anything else to add from any of the panel members?
Hi, I just wanted to add briefly that in low resource settings, adding in a rotation can be practically very difficult because rotations are tight and there's a lot of clinical burden. But adding it into the medical school curriculum, can you hear me? Good. Adding it into the medical school curriculum is actually much easier. And by adding it into medical school curriculum, we actually potentially reach a whole lot more people. So that's what we've done at the University of Cape Town, at the University of Stellenbosch. We have teaching around maternal mental health, and certainly there's teaching around child health and infant mental health. And then we have ongoing professional development programs, continuing professional development. And we do a lot of work around maternal mental health, reaching out to people who want to upskill themselves.
Thank you, Bobby. I'm just mindful of the time. I think there's a lot of things. There's a lot of food for thought from these discussions. Clearly, there are research and training gaps that need to be looked at more so in low and middle income settings, but also there's quite a bit that can be looked at in other countries as well. So lots of learning from the presentations today. So I once again would like to close this. Thank all the speakers in the panel and also Subodh for this very interesting and thought-provoking panel discussion. And I would like to close this webinar by thanking everyone who has been part of this very successful grand rounds today. And special thanks to the patient who shared her journey today. It was really interesting and very powerful to hear her journey. And thank you to Kezia and the RC Psych Calc team for running everything in the background and keeping this session going in a smooth manner. And thank you to everyone joining us from all over the world today. And we hope to see many of you in the next Grand Round session, which will be on the 28th of November. So thank you once again for joining.
Thank you for having us.